Pre- and postoperative care. Postoperative. The postoperative period begins when the client is admitted to the post-anesthesia care unit, PACU, also known as the recovery room. The recovery room will be located near the operating room, which enables surgical and anesthesia personnel to be readily available for any emergencies. The anesthesia personnel and circulating nurse will transport the client to the PACU, and anesthesia personnel will stay with the client until they're assured that the client has a good airway and is overall stable. The PACU nurses are knowledgeable in caring for clients recovering from anesthesia. The initial postoperative nursing management includes monitoring for airway patency, effective respirations, using artificial airways or mechanical ventilation, and the provision of oxygen. Circulatory status will include monitoring the wound condition, the dressing, and the drains, in addition to the vital signs, the blood pressure, circulation, cap refill, etc. Fluid balance will include IV fluids or a urinary catheter or drain output. The PACU nurse will also monitor the level of consciousness and pain and monitor for potential complications. The Aldrich scale is a tool that's used to assess how well a client is recovering from anesthesia. It rates the client's mobility, their respirations, blood pressure, level of consciousness, and pulse oximetry. Postoperative complications include hemorrhage. The PACU nurse will assess for symptoms of shock, inspect the dressings, and continues or initiates blood transfusions, reinforces dressings, and monitors those wound drains. Shock. The PACU nurse will monitor for fluid and electrolyte loss, trauma, monitor anesthetic effects. Medications all contribute to shock, so they'll be monitoring for those. They may treat it with blood or plasma expanders, IV fluids, oxygen, and medications if necessary. Residual drug effects, pain, positioning, pooling of secretions, or an obstructed airway can all cause hypoxia, which is another complication. Oxygen and suction equipment should be available, and it's necessary for the PACU nurse to assess for signs of cyanosis and dyspnea. Aspiration from saliva, mucus, vomitus, or blood can also occur until the client is awake and they're able to swallow without difficulty. So it's necessary to have suction equipment at the bedside. The nurse will assess for difficulties in swallowing, and sometimes a side-lying position might be helpful to prevent aspiration. Wound dehiscence will be the separation of the wound edges without the protrusion of organs. It's likely to occur within 7 to 10 days postoperatively, and risks will include poor nutrition, chronic disease, being an older adult, increased abdominal tension, obesity, and infection. So it's important to decrease the strain on the incision and notify the surgeon if dehiscence is noted. Evisceration will be separation of the wound edges with protrusion of organs. That has to be covered with sterile dressings moistened with normal saline, and the surgeon must be notified. Often, dehiscence and evisceration will require packing of the wound with appropriate packing materials. Packing material has to touch each edge of the wound, but it should not be stuffed into the wound to create bulk. A paralytic ileus is another complication where the intestines are paralyzed and there's no peristaltic activity. These clients may require nasogastric tubes and NPO status until the bowel sounds return. Pneumonia and atelectasis, or the collapse of alveoli, are possible because of drug effects, failure of the client to take deep breaths, and immobility. The older client is most at risk for these complications. In addition to the obese, clients with COPD or clients that have chest or abdominal surgery are at an increased risk. Infection is indicated by increased wound pain or discharge, erythema, increased warmth, edema, and purulent exudate, in addition to potentially increased body temperature that may require antibiotics. It is increased with traumatic wounds, wounds that were not treated promptly, or wounds that were infected preoperatively, in addition to clients that are obese, immunosuppressed, or have diabetes mellitus. Now, infection should not be confused with the normal inflammatory response of a surgical wound. Thrombophlebitis is the inflammation of veins with the formation of blood clots, usually caused by long periods of immobility. These clients will be at increased risk for pulmonary emboli. Anti-embolism stockings or sequential compression devices might be used to reduce the risk of blood clot formation in the legs. Later postoperative nursing period will begin when the client arrives to the hospital room or the post-surgical care unit. The assessment will include respiratory status, circulation, pain management, fluids and nutrition, skin integrity, wound healing, activity, bowel elimination, urinary elimination, and psychosocial status. So the nurse should assess the respiratory and cardiac function, the client's general condition, vital signs, fluid status, pain level, elimination and flatus, dressings, drains, IV lines, etc. when they arrive to the floor. With the respiratory status, encourage deep breathing exercises, the use of the incentive spirometer, and teach them how to splint the incision. Supplemental oxygen will be provided as necessary, and we need to encourage frequent position changes and early mobilization. The circulatory status will require assessment of the blood pressure and potential orthostatic hypotension, assessment for bleeding and venous circulation impairment in the form of deep vein thrombosis, which could break off and become pulmonary emboli. Postoperative pain will be at its greatest 12 to 36 hours post-procedure. Pain should be treated before it becomes uncontrollable, and pain that is unrelieved by medication can indicate there's complications. With IV fluids and nutrition, we will probably be administering IV fluids, and dietary progression will be dependent on the type of surgery, the client's progress, and the physician's order. The nurse should assess for nausea and vomiting. A nasogastric tube might be placed in an abdominal surgery to help rest the gastrointestinal tract. Nursing guidelines for resuming oral fluids will always be based on the orders of the physician, but usually the client will be NPO, and the nurse needs to assess for bowel sounds. GI activity might not resume for 24 to 48 hours. That is normal. Assess the swallowing of the client and introduce sips of water or ice chips slowly, usually within 4 to 24 hours postoperatively, unless it was a gastrointestinal surgery. Administer antiemetic medications if the client becomes nauseous or vomits. When able, promote protein, calories, vitamins A, C, and zinc for wound healing and immune system function. The nurse also needs to assess skin integrity and wound healing, so that requires a wound assessment. Look for wound devices. Drains are going to remove fluids from the wounds. They can do this passively or actively with suction. A Penrose drain will be flat. It's a silicone type drain that's placed deep into the wound, and it lies flat on the skin outside the wound. There's often a sterile safety pin placed in the portion of the drain that will lie on the skin to help prevent it from sliding all the way back into the wound. A Jackson Pratt or a Reliavac drain would be a hollow silicone tube, or it's a bulb attached to a tube, and it has a cap on the bulb to drain and measure the exudate. The tube is placed near the wound through a stab site. The cap is open and the bulb is compressed, and while holding compression, the cap would be replaced, and this creates the active suction activity. That drain is often secured to the client with a suture, and the bulb itself is often secured to a dressing or the client's clothing with a safety pin through the tab that's on the bulb to help prevent dislodgement. Another type of drain is a circular drum-shaped spring-loaded drain. It's often referred to as a hemovac, and this is another option. We frequently will see this with orthopedic surgeries. Just like with the JP drain, when the cap is open, the drain would be compressed and then the cap is replaced. And this creates the suction. The drain can also be secured to the client with a suture. It's one of the drains that might have the option of reinfusing sanguineous exudate. This drain usually will have a clip similar to those that you will find on an indwelling catheter, urinary catheter, that secures it to the bed or the client's clothing. The client may have a nasogastric tube that's inserted through one of the nares, and it's attached to low intermittent suction. Not continuous suction. Continuous suction may cause it to suck up to and adhere to the intestinal wall or the stomach wall, and that can potentially create an ulcer. These tubes are going to be secured to the client's nose with some type of device or adhesive. The tube is often secured then to the client's gown to help prevent dislodgement. Wound assessment will also include assessing the approximation of the wound edges. Is it still intact? Are the staples and sutures intact? Are there any signs of infection? And reactions to the adhesive or the dressing. Phases of wound healing would include the inflammatory stage, the proliferative phase, and maturation remodeling phase. There's 3 types of wound healing. We have primary intention, which is the healing of a wound with the edges that are well approximated, and this is done with sutures or staples. Secondary intention is the healing of a wound from the bottom up, and those edges are not approximated. Tertiary intention is the leaving of a wound open initially and then going back a few days later to suture the edges. Factors that do affect healing would be impaired circulation, malnutrition, hyperglycemia, infection, foreign bodies, age, and immobility. Again, signs of wound infection include increased incisional pain, redness, swelling, heat around the incision, purulent drainage, fever, headache, or anorexia. And complications of an infection include dehiscence or evisceration. The client's activity should be advanced as tolerated as soon as possible, and it may be necessary to administer pain medications approximately 30 minutes to an hour prior to the ambulation to encourage compliance. With regional anesthesia, however, initially activity is going to be restricted until feeling returns. And if the client does experience a spinal headache, remaining lying flat may help that headache, and it may require a longer period of time. The nurse needs to monitor bowel elimination and/or flatus. Abdominal distension, might be caused by narcotics, the diet, and inactivity. So the first thing we would do if we do not hear bowel sounds, or the client has just refused to get out of bed, is to encourage ambulation. We have to also do frequent position changes and advance the diet per orders. A paralytic ileus is those paralyzed intestines. So we see acute gastric dilatation, and that would be a stomach that is dilated with fluids. Urinary elimination might also be difficult after surgery. So if the client is unable to void within 8 hours postoperatively, we encourage voiding. But if they cannot void, these clients may require straight catheterization. Psychosocial status might also be altered because of changes in body image or lifestyle. So assess for any issues and refer them for counseling or support groups as necessary. Gerontological considerations. The older adult can develop confusion and disorientation with narcotic and barbiturate use. Respiratory depression risk is also greater in the older adult with narcotics. And the older adult may have a delay in healing due to thinner skin and loss of subcutaneous tissue. In addition, the anesthesia may hang on a little bit longer with the older adult. And the older adult is at increased risk for infection because of a diminished immune response. So which intervention would be indicated for a client with thrombophlebitis of the leg? Encourage fluids by mouth. Gently massage the affected leg. Keep the leg positioned below the level of the heart. Or start antibiotic therapy. The correct answer is encourage fluids by mouth. We need to make sure that these clients are adequately hydrated. Dehydration or fluid volume deficit does increase the thickness or the viscosity of the blood, and that is a causative factor in the development of thrombophlebitis. Discharge instructions should be verbal and in writing. These clients are not going to remember everything you've taught them. They need to have something in writing that they can refer to at a later date. Determine the client's needs, including their ability to care for themselves, the need for supervised home care, what supplies they might need at home, or special dietary needs that may be required. Are there any adjustments to their living environment that will be made once they return home? And what types of pain medications are they going to be taking? Discharge instructions should also be reviewed with a responsible adult other than the client, and they should include medications, wound care, activity, including bathing and driving, the client's diet, when the doctor should be notified, and to keep all follow-up appointments.